Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, and welcome to VITALS, Value, Innovation, Technology, Advocacy, Leadership, and Service. Those are the tools that today's healthcare leaders use to transform healthcare, making it more affordable and more accessible for our communities. Today's vital speaker is Dr. Yoleetah Ilodi. Dr. Ilodi currently practices internal medicine and geriatrics for Summa Health, where she is the lead physician for diversity, inclusion, and recruitment for medical education. She has worked as a diversity health consultant both locally and regionally. Dr. Ilodi recently completed a 2-year term as NEOMED's first ever Assistant Dean of Diversity in the College of Medicine. In that role, she was pivotal to helping NEOMED increase its student enrollment, diversity, providing leadership, oversight, and strategic vision for policies and initiatives to promote inclusion and equitable learning and working environments for students, faculty, and staff in the college. Dr. Ilodi is an associate professor of internal medicine in the College of Medicine and continues to serve on the college's admissions committee. As a clinician, she is a multi-award-winning teacher and respected by both students, staff, and administrators for her advocacy for equity and justice. Dr. Ilodi earned her medical degree from the University of Cincinnati College of Medicine. She completed her internal medicine training at Summa Health, where she also completed a fellowship in geriatric medicine. Dr. Ilodi, welcome. The floor is yours.
Greetings, NEOMED community, friends, and partners, and beyond. Thank you, Dr. Langell. My name is Yoleetah Ilodi, and I am a proud NEOMED clinical faculty at the Summa Health campus. I wear many, many hats, as Dr. Langell has said, but my main hat is of diversity, equity, and justice. I am a huge proponent of patient care as well as learner diversity, equity, and justice. I am going to bring up my PowerPoint, and hopefully this will work here. So one of the things that I feel that is extremely important is before we do any discussion, we want to get on the same baseline about what our vision, what my vision is for diversity, inclusion, and justice. My goal is to cultivate equitable health outcomes. And that's really one of the reasons why I went into this, is to infuse all of this. So not just integrate, but to infuse justice into undergraduate and graduate and continuing medical education spaces. We want to dismantle policies that perpetuate inequities, and we want to connect with all of our stakeholders to properly address issues. And when I say all of our stakeholders, medical students, residents, core faculty, program directors, DIOs, basic science professors, undergrad partners. And we want to emphasize the value of health equity as quality and safety. I would also like to make a land acknowledgement that we are so grateful, that I am so grateful. Again, I'm going to put this back on myself, that I acknowledge the many diverse indigenous nations, past and present, including the Ohio Seneca the Kaskasaki, the Lenape, the Ottawa, the Mingo, the Abenaki, the Tobago, the Erie, and the Abujagi. These lands were ceded in the 1805 Treaty of Fort Industry and the forced removal of tribes through the Indian Removal Act of 1830. I extend my respect and commitment to the process of continual learning, reflection, and justice. So the cost of health equity in healthcare. So today I'm here to address a critical issue. Some may say a public health crisis, which is the cost of inequity in healthcare. The reality is access to healthcare, we say, is not a privilege, but it's a fundamental right. A lot of us say that. Yet far too many individuals are denied this right, or they are given this variant of gray, a spectrum. This creates this devastating consequence that we all know and that we've all seen. I like to level set, as I said. I like to start off with definitions, which are critical starting points for this fundamentalist brain and imagination, because I feel that they're good starting points and markers. We're trying to move to a destination together of shared understanding. And I feel that it's a good way for us to chart our map as we work our way through. So what do I mean by cost? So I'm not just speaking about money, but I'm speaking of consequences, not just price. And I like to say it a different way. I like to maybe use the word damage, or maybe perhaps said a different way. What is the toll? What is the sacrifice? But I do think that my favorite way to say it for the cost of inequity is, what is the ransom? Because it was something that was ours, that should have been ours, that was stolen. And how are our individuals, are us as individuals, peers, colleagues, leaders, institutions, friends, families, organizations, medical students, what are we doing to settle that charge? There are many definitions of health equity out there. I went with a single source. That doesn't make that single source correct. I did add my own flavor to it as well. So this one comes from the CDC. It is the state in which everyone has a fair and just opportunity to attain their highest level of health. This requires addressing avoidable inequities that are historical, contemporary, social determinants of health, disparities, and dismantling isms. Everything in the red is mine. I had to change it because this needs to fit with the narrative of what we're doing today in the world. And the way I like to talk about is with equity versus equality is, look at this picture. You may know some of the folks in this picture here, right? So you got me, my husband, and partial of my crew. This is not all of my crew. You know, my son is 10, and then you have my son 8, and both of us. And you guys will probably all agree, right? We all need different things. The boys, you know, they need different things. As a matter of fact, even at their ages, they too have different nutritional things that they need. They need physical activity, physical intensity, attention, you name it. There's so many different types of things that they need that are just different. And as parents, if you're a parent, you know you meet those different needs and nobody thinks it's a big deal. Well, that's health equity. You're meeting the person where they're at. You're giving them what they need to be at their optimum health. And a matter of fact, one of the things that I like to talk about quite a bit is one of the things that we often forget is that there was a pivotal moment between the 1960s and 1970s. And oftentimes we remember historical perspective between race and ethnicity and gender and class. But we remember that a lot of our laws started in the 1960s, right? With the Civil Rights Act of 1964 and the Voting Rights Act of 1965 and the Fair Housing Act and the Title IX Education 1972. So remember that all of these things that we discuss are all fairly new to this country. So what are health disparities? All right, so I talk about health disparities quite a bit, but they are preventative differences in the burden of disease, injury, violence, or opportunities to achieve optimal health, closely linked to social, economic, and environmental factors, racial or ethnic group, religion, social, economic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation, or gender identity, geographic location, or characteristics historically linked to discrimination or exclusion. Again, we go back that a lot of these laws have just been enacted. And so we have to go back there to remember all of these things are fairly new. For example, the Americans for Disabilities Act just was enacted in 1990. And if we look at this, we know that our LGBTQ youth here are at higher risk of suicide, not just considered suicide, but actual attempted suicide. And this was a study of 35,000 LGBTQ youth between the ages of 13 and 24. You see here, I picked on Ohio a little bit. You see there's an overlap between cardiovascular disease and poverty. The percent poverty being in the dark green, I call that green. And if you look over to the other side with the red, you see the darker red indicates more cardiovascular disease. And then again, if we look at the incidence of cancer here, if you look at the incidence of cancer, the incidence rate, you'll see in the Black community, and females are higher, and Black males, excuse me, are higher than in white males. And so is the death rate. So this is my fun part that I like to talk about. So you just have to excuse me because I love to bring in who I am into the picture. I am the granddaughter of Barbara Jean and John Townsend and the daughter of Phyllis Yvonne Richards. And I like to call it out like that because my family has taught me so much. I grew up in a very, very close-knit community. And my grandfather came and my grandmother came up from Alabama. And for those who know me, yes, they are still alive. I'm very, very blessed. But they came up in the 1950s. And if anybody remembers that the name of this time was the Great Migration. And that Great Migration was between the time of 1910 and 1970. And it's estimated that 6 million Blacks left the South at that time. For many of you guys know that if you have ever met some of these people that have come up from the Great Migration, they're some of the warmest, kindest, close-knit people you ever want to meet. They're very warm. And they had to make family. They had their friends became their family when they came up. And so one of the things that my family has taught me, especially, my grandparents being, spearheading this, and that's my grandfather and my grandmother right there. That's my grandfather with his Kumo J hat on, and that's my beautiful grandmother. My family taught me the power of community and connection. And that has been a great reward my whole life. I have tried to make sure I connect with people to see how I can support them. And so that was a natural for me to want to go into medicine and to do that. But they also taught me the meaning of service and looking at the whole person. So not just as a physician, but just as something that's talking to a human to another human. And so that was something that I was able to take into medicine and carry into medicine with me. And the reason why I bring that up is because we're not just talking about a cost that is $360 million that is going to go up to, predicted to go up to $1 trillion by 2040 in healthcare costs due to health disparities. We're talking about trust, and connectiveness. We're losing that with our patients. We're losing that trust and that connectivity with our patients. Trust with our community is at an all-time low. What has happened to us being able to have that? I've been talking about this patient, and I'm gonna be good because I know how to follow the instructions of all of this, but I want to talk about this case here. A 47-year-old female identifying person. She has a past medical history of migraines and acid reflux. She had a gradual weight loss of 25 pounds 2 years ago. And you review the chart, I reviewed the chart, everything was negative. There was nothing that we saw that was really, pointed to why she would have had this weight loss. She hasn't been to the doctor in about a year, and she lost like another 10 pounds. She looks tired, she looks worn out. And her everything else is normal. She comes in, she looks normal. I mean, she looks tired, but everything is normal. Her labs are normal, her imaging is normal. You let her, do you let her go home? No, you don't let her go home and just say, okay, bye-bye. You talk to your patient. You figure out what is going on with your patient. You find out that there may be limited transportation. You find out that this young lady is a caregiver to an aging father who has dementia, and she don't have time to go to the doctor, or she doesn't have money to lose out by not going to work. She doesn't have a whole lot of money to spend in the grocery store, so she limits how much she eats, and that's why she's losing weight. But you got to be able to, again, you got to be able to connect with your patient to be able to get that piece of information out of the patient. We call this social determinants of health, but again, it's not just a checklist. All of these are interconnected to each other, and they play a huge role with each other. And it's not just health, but if you're not healthy, how are you going to school? If you can't go to school, how can you work? Everything connects to each other. And it's important that we understand how all of these work into each other and that these cause disparities in health. So what can be done? What can be done? There's not enough doctors. There's a whole lot of money, but there's not enough resources. We can't spend enough money. Doctors are stretched out, burnt out, tired. So what are we to do? Are we to get more empathy, more training? What are we to do? One of the things that I look at is I start small and go big, or I go big and go small. But what we need is to start a conversation to assess, implement, and repeat. And anybody who has seen me work, that is exactly what I do. I assess a situation, I implement, and I repeat. We have to start somewhere. Conversation, start doing something in our communities, in our hospitals, in our organizations, because these things are happening and the gap is getting larger. We can put in more doctors, we can put in more time. But the most important thing is if we connect with our patients, we start to ask questions. We start to work on what we can do better for our patients, to connect with them as an organization, to integrate, to increase our diversity, to infuse justice seamlessly into our curriculum. This will show us that we all can do better. This is one of my favorite quotes from Martin Luther King. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Thank you. Thank you for your attention. And now we will have a Q&A moderator by Monica Robbins of WKYC Senior Health Correspondent.
Thank you, Dr. Ilodi. That was, first of all, I'm very happy to see we have over 84 participants in this discussion today, and we already have questions. So for any of you who just listen to this and you want to ask more questions about DEI to Dr. Ilodi, please put them in the Q&A and I'll be happy to ask. Our first question comes from Pete. He wants to know, where does competence and teamwork fit into DEI?
So that is a great question. Competence and teamwork. So it all starts with a team, because when it comes to diversity, equity, and justice, it's all hands on deck. Of course, there's always things that you can do on an individual level, but you really want to start working at a team level to really get some of the big work done. Now, when it comes to competence, people like to place cultural humility against cultural competence quite a bit. And I say, hey, look, boys and girls, we ain't got to fight. We don't have to fight. They can all fit in the same room together. It's not a zero sum, because sometimes you don't know what you don't know. So for example, if I know a certain group may or may not eat a certain type of food, I may not know to even ask. So I need to know a little piece of it to don't even know to ask that question instead of walking around totally blind. So I think that we need to know something and have some, I wouldn't say competence, because that makes it sound like there's a destination. We need to read up just like we read up on anything else. We need to have an understanding of the folks around us.
Rod wants to know, are the current discussions across the country regarding academic freedom and divisive concepts a threat to advancing DEI?
You may have to repeat that, because that's a loaded one, and I think that's a three-part question, actually. Okay, go ahead.
All right. Are the current discussions across the country regarding academic freedom and divisive concepts a threat to advancing DEI?
So if I could answer this a little bit backwards, in terms of threat to DEI, DEI has always been a threat. Since this came out, since the first report back in 1984 that described health disparities, it has always been, a threat out there. In terms of the divisiveness, I don't quite see that as, as that being an issue, but perhaps it could be. I don't see it as an issue. I think that we can all integrate this into patient safety and quality, because when you look at the fact that when you take a situation, I use the example of, and if you guys, so sorry that I use a lot of examples, but that's just how my brain works. Patient care, the 15-minute rule. So if you take someone who takes public transportation, for example, and you tell that person, hey, you're late, you can't see the doctor. And she's like, well, my bus was late and I'm so sorry. And then you tell her, I can't see you. And so many times that happens, you can't see that person. Well, what about the lady? Yes, she might be driving a really nice car, but what if she got lost in the parking lot? Are you going to say the same thing? Yeah. But guess what? Wouldn't it be nice if there was just a little bit of grace on both sides? Oh gosh, that would be nice to have a little bit of grace on both sides. Everybody wins is what I'm saying. So when you look at things and look at policies from a lens of equity, everybody gains.
All right. Elaine says, thank you for your leadership at NEOMED, and she appreciates your comments on the Great Migration and the case history you presented. Can you talk more about what you mean by the term justice and how you talk to students about practicing that with their patients?
Absolutely. So, we all have good days and we all have bad days. Our patients have good days, our patients have bad days. What does justice look like? Justice looks like I'm gonna make sure that this is gonna balance out. Okay, you have not gotten your share of my attention as a doctor. You have not gotten what you've needed of me. And I'm just using me as an example these past days, because you've been this quiet patient. But now I'm going to spend all of this time, because we have catch up. I have to now learn so much more about you. It's not in a vacuum. There's catch up to be done. And so just like we as a people, and I can say me as a Black woman, there's catch up that I needed to do. I had to catch up. And there were people who had to allow that to happen and give me that space to happen. And that was called justice. And for them to give me that space, that literally meant they had to step out of the way to give me that space. And that is what I tell my learners, and that's what I tell my patients, is that you will then have to step out the patient's way or help facilitate something for your patient. So for example, if you have to call in a prescription for your patient specifically to help them out with something, or get some extra, call in the appointment for them, or do something, go above and beyond, that is what justice is. If you have to ask the social work to help, that is what justice looks like.
Diverse teams help in getting different viewpoints in the room, but how can we improve the attention we pay to minority voices? And this is from Janet, and she means females too.
Say that one more time.
Diverse teams help in getting different viewpoints in the room, but how can we improve the attention we pay to minority voices? And she says she means females too.
How can we, I guess I don't, I'm not, I guess I'm not really, is that more of a comment or?
Well, I think she's saying that she, you know, when the medical team is diverse, that always helps getting different viewpoints. But how do you improve the attention you pay to minority voices? Almost it sounding a little bit on the lines of systemic racism, even though it's, you know, many times it's unconscious.
I guess I'm looking at it, is this from the patient side or is this from the trainee side?
Janet, if you're there, can you type in?
Yeah, so I guess that's what, because, you know, I'm looking at both sides of the.
She says both.
Okay, all right, thank you so much. So really, I advocate for our patients and for our attendings, again, and when we speak about justice, again, if I'm going back around and you're talking about doing second rounds is when you all go see the doctor, like you see all these people come in your room in the morning, and then second rounds is when the attending just kind of comes back by themselves and has that like heart-to-heart talk with you. That's a good thing, like implementing that, and that attending is sitting down and having that heart-to-heart and being able to talk to that patient of color and sitting and talking to them eye to eye and connecting and trusting. And so again, giving that time, but then you end up giving that time to everybody. But you're giving that time because you know that there are particular groups that need that time, right? So you end up giving it to everybody, so everybody wins. So that's justice, right? And when it comes to justice, everybody wins. When it comes to learners, sometimes you have to facilitate allowing them to have voice. Sometimes they're going to be a lot quieter because of the treatment maybe they have had in the past, where possibly their voices were not valued. Maybe they were, I don't want to say the word shunned, but they were dismissed or rejected when they tried to speak up for themselves or said something in class. And so you have to give space for them and really encourage that as an attending physician, a supervising physician, where you have to encourage your interns and role model that behavior for your senior residents as well.
Victor wants to know, could you please address language barriers as a determinant of health? And how can we improve our outreach to non-native English speakers or non-English speaking patients?
Ooh, you speaking my language, Victor. Let me tell you. So we talk quite a bit about what we call the class standards in Title VI, which is a part of the Civil Rights Act of 1964, is making sure that our patients have proper translation services. And a lot of times, in my head, that means that even the information that is printed out for you is in proper translation, but that is not the case for almost any hospital. They can print out things in English even if you don't speak a lick of English. It doesn't matter for them. And that is pretty tough. Well, how we can improve it, and this has been some studies, it's really using our community health workers as coaches. Again, looking at the fact that even if it is printed out in their native language, the translation may not be correct. And so we want to make sure that we have connectiveness with our patients. Again, having an actual human to say, hey, do you understand your medication? Community health workers have been used in the past in many places and have been successful. And so now that we know that they're successful, we really need to get them out there in that community, and we need to do better by them.
How can students stand up to or address the bias they observe from those who have a power differential, whether in a clinic or a classroom?
That is always tough. And, it's all about the comfort level. Everybody's comfort level is different. I'm pretty introverted. And so I typically would just ask questions of, if they were, they say my name a certain way and say, use the example, hey, my dog's named after that, or, something like that. I would just, ask a question that's, repeat what they've said, or, I may tell somebody that's an authority, but really you have to be direct. That's the only thing that I've found that works in the end. You can't sugarcoat it. You have to be direct. And if you want to save your energy, you can write it down. You can speak it into your document, speak it into your phone. So later on, you can, when you feel a lot better, you can kind of clean it up a little bit. But you got to be direct in how you feel. So I would encourage for you to get your feelings out, get them out on paper. Maybe wait a day or two till your emotions, clean it up a little bit so that it's nothing that you would say, oh my God, I can't believe I wrote that. And then you, in your terms, in the way you want to be able to send that and let them know, CC a, dean or core faculty member so that they also know what's going on.
Since you work with both current and future health professionals on advancing DEI, compare and contrast the general understanding of DEI between the two.
Oh boy, y'all don't want to hear this. Okay, so I'm gonna say this. Medical school, so as you guys know how it works is medical schools are further in the game than graduate medical education. Really, graduate medical education is truly learning from UME, what we call medical schools, as undergraduate medical education. I was probably 1 in 10 in the country that was doing DEI in GME back in 2012. So, it is truly new. Dr. McDade, who is our Chief Diversity for ACGME, for residency is, I want to say he started maybe 2018. So again, this is very new.
A lot of our hospital systems are still focused on sick care, and social determinants of health, however, are being brought up more, but I would venture to guess more needs to be done. The other issue is systemic racism. What can medical schools do to address that, because you're getting students from a variety of different backgrounds. And if they were raised a certain way, how do you change that perspective in medical school? Or what would you expect medical schools to do in teaching these subjects?
Boy, that's hard. This is when I always like to have a panel up, it's hard to change folks' mind. And I think, maybe I'll change, in my life, because, I'm just old and crotchety at this point. But, you teach them to be, you can't, how do you teach somebody to be humane? And so really, are you really going to be able to teach somebody basic sciences in medicine and teach them how to be humane? And that's why I do like the word professionalism. Like, okay, that's fine, but you're going to be professional. so, I think that's tough. If that's what they and how they decide that they want to think. But what I do feel that we can all do better is making sure we infuse diversity, equity, and justice into our curriculum seamlessly, and not make it a other. And so, for example, not make it a whole separate course, not make it a whole separate certificate or department. It's something that should be integrated into each class. If we're talking about the cardiovascular system, we're talking about healthcare disparities in the cardiovascular system, not something that is talked about separately. And again, this is not specific, by the way, to NEOMED. This is just specific to many other medical schools, including some of the ones that I've been to just recently to visit. If we're talking about the renal system, talk about how we use the correction modification for years, since 1994, a correction system that promoted unjust, I won't say the word unjust, but promoted creatinine to look like the kidneys was better than what they should have been in African Americans, and therefore delayed kidney transplant in African Americans.
Some of our systems, before a patient is seen, they'll have them answer a questionnaire, and the questionnaire is have you felt sad in the last 2 weeks or something like that? Would you like to see more questions pertaining to social determinants of health added to that? Would that, in your opinion, make a difference so doctors can address those issues up front because they already have some of that information?
So we have those in our electronic medical record. Problem being, a lot of times they're incorrect. They're not marked correctly. But what I would like to see is for those to be addressed. So right now we're collecting that information and it's just sitting there. And you know me, well, why we ask if we're not going to do nothing? If you just asked her if she had transportation, and then when she said no, we ain't do nothing about it. So, I just have a difficult time. If you can ask somebody if they're hungry, then you should probably feed them.
Yeah, great point. What do you think really needs to change almost immediately for DEI to be truly effective?
I think it needs to be placed under quality and safety. It needs to be a part of it. It needs to be seen as something that is pivotal for patient care, for patient safety, checks and balances. Because what we're finding is that some groups are getting care at a higher level and other patients are not getting that same care, but they're dying. They're just not doing well. They're dying because of it. And that's a safety issue, in my opinion.
I want to remind our participants, if you have any questions for Dr. Ilodi, please put them in the Q&A section. Of course, today we're talking about diversity, equality, and inclusion. I'm curious to know, you talked about these issues being relatively new. We've seen, diversity officers going into hospital systems in the last, decade, if not in the last couple of years. So let's look at the brighter side. We are talking about it. So where do you see medical education in this issue in the next 5 to 10 years?
Medical education has really has been very transformative. And I really see, especially student drivers. The students have so much energy and they are so creative. And I'm really seeing the medical schools listening and really trying to implement some of the things that the medical students are asking for, and trying to improve their environments, trying to recruit more, trying to make sure that they hear the equity piece of admissions and what needs to change. Noticing that they know their boards need to be diversified. Their faculty needs to be diversified. And, I see a lot of places trying to reach for that. So I really see that undergraduate medical education going very far with this, doing much better, integrating, learning from each other. They're very highly invested. I went to the AAMC back in November, and this was the talk. This has been the talk, and folks are very highly invested in doing better at their organizations.
You brought up some personal history. We saw your husband, we saw your kids, but maybe some of our participants aren't aware. It wasn't easy for you to go to medical school because you were also at home raising a child, right?
Yes.
Can you talk about that and what were the challenges to going to medical school, and what did you learn in those times if you were seeing your own doctor?
I had a little person, and she was absolutely just, she's still amazing, by the way. She's still amazing. She lives in Austin, Texas, with my 2 little sweet grandbabies, Samir and Zakari. And what I learned is that everybody just wants to be treated with kindness and patience. I was in medical school, and at the time I had Medicaid, I had care source, and I didn't want to be treated any differently. You notice that some people treated me different, because when they found out I was a medical student, they're like, oh, like it was like, oh, but you're different. I was like, trust me, I'm not. I'm not different. I had Section 8. I was, I had food stamps. I had all of that because I had to, I had to raise my daughter. So I had to do what I had to do to be able to get by. But it was tough. And when I went to the doctor, I just wanted to feel human. I wanted to be seen. I wanted to feel safe. I did not want to feel like I had to watch my back and ask 1,000 questions. I just wanted to be able to trust my doctor, to trust my daughter's pediatrician. And I was very lucky, because at University of Cincinnati, they had some of the best doctors down there at Children's Hospital. But again, oftentimes, at the pediatrics level, you do get that good care. But as an adult myself, I didn't seek healthcare until, I became an attending physician myself, because it was very hard to find a healthcare professional that would even take Medicaid at the time.
We have another question. Rod wants to know, are DEI concerns unique to the US, or is DEI a global issue?
It's absolutely a global issue. They're right there with us. Several studies, and I could just say, I don't know a whole lot about a lot of the global issues, but I do know, as I'm pulling up, I do a lot of research, and I'm pulling up a lot of articles. I see the articles from the UK and from Germany and from many countries that are trying to, again, do better. Canada, well, I just read a paper from Canada that are trying to do better. And even specifically just read a paper from Canada based on the Indigenous population.
For these medical students who are listening to you right now, if there's one thing they can take with them when they graduate and begin practice, what do you hope it is?
As in regards to, I'm trying to think, it's so much I could really tell them.
Well, go ahead. We'll take one thing away. What is it that, give us the top 10, if you would.
Okay.
What are the things that, that maybe doctors in the past did not get out of medical school, relating to these issues?
And hopefully I don't sound like the little old lady. I know they're probably like, oh my gosh, Dr. Ilodi, you didn't told us this story. But again, don't let anybody tell you who you are. You are who you are already. You're a great person. Don't be anybody except for the person you are in your skin. Don't lose your humility. That's what I love about trainees, medical students and residents. You guys have so much humility still. That's why you guys are like my happy place, because y'all still see patients as what you should see them, which is humans. And you guys are not managing people. You actually want to help people. Sometimes in the hospital, you see just the management of patients and you don't see the helping of patients. And that can become a little bit scary after a while, but you guys just breathe a lot of fresh hope when I see you. So be who you are and don't lose that. Don't lose that humility to be able to want to help patients, and helping patients is sitting down, talking to them and connecting with them. And that doesn't have to take a whole long time. That just takes time to want to lean in and have a conversation that it's not over anybody's head. I would say sometimes you're going to just have to study hard. That's just it. They know how I feel about the word burnout. Sometimes you're just going to have to study. That's just what it is. That's a part of life. Get it done now. You won't regret it. You'll look back and just be happy. And just know that it's all worth it in the end, I promise. And 3, I would say most of everything is make sure that you continue to speak up for yourselves. You guys have the energy. You guys are creative. Your generation will create things that my generation has never, ever, ever could ever have fathomed. So, I apologize that you're going to have to fix the problems that we didn't fix, but you guys have the energy and the creativity to be able to do it.
We have another question. How do you help medical students understand the importance of advocating for just and equitable policies and procedures? And I would venture to guess, once they're working in a hospital system, how does one doctor stand up and say this has to change?
Yeah, and that's what's really tough. And I'm not, and all of this is coming from just my heart. That is really tough. When I was seeing patients every single day, it was so hard to be able to, because it's how fast you go, how slow you go, how quickly your patients come in, and how many emails you can send out and read in one day, right? And really being at the administrative level, but then even at that level, then you're not seeing a whole ton of patients. And so it's always a catch-22. Really is going to make sure you're sitting at the table for these meetings and these committees when they're making decisions. Looking at these policies through a health equity lens, constantly asking why. I assume that every policy that is on there was not made for women, people of color, LGBTQ. Again, because you heard people with disabilities, you heard what I listed, because these laws and policies were enacted prior to the laws. They're still on the books. So we have to assume that it was not made for us.
Are the organizational behaviors worse in hospitals? Do healthcare professionals need better leadership training?
it's really hard to say. You see the good, you see the bad. I don't want to start singing the facts of life, but it's just, you see some good doctors, you see some not so good doctors, but I think overall, I'm blessed being at Summa Health. We have what I feel like is great leadership. And especially in hard times like this.
Before you walk into the room to see a patient, are there any questions you ask yourself to make sure you ask them?
You know what? I check myself at the door because I can sometimes give people what I call my representative, my avatar. And so I check myself at the door so that they get a whole person that walks in. They'll get Dr. Ilodi and they'll get somebody who is very professional, but they'll also make sure I have this hybrid that they see that I'm also a whole person walking in, and that I want them to know I see them as a whole person, not just a disease. I see that you have bedside, your mom, your dad. Oh, and I see you have a picture, and I see, tell me what's going on. I don't see somebody who's struggling with, an addiction. I see who they are and how can I best help. I may not be able to fix it because I don't believe in all of that, but how can I best help them in their situation?
Dwayne wants to know, what do you see as challenges you may have in your position now, and how can diverse alumni and community physicians in the community assist you?
I think the biggest thing is that we have a lot of students. They want mentors. They want active mentors, and really just reaching out and saying, hey, you know what is it that I can do? There's always there's always plenty of work. We do a brunch every year for our medical students as they're coming in. We would love for folks to join in that, whether it's just dinner, taking them out to dinner. They are just absolutely fantastic. I could just hang out with them just because it's a Sunday. They're just absolutely a hoot.
Terry wants to know, I'll give you the compliment first. Dr. Ilodi, I have great respect and admiration for you. You exemplify humility and connection with patients and students. Here's the question. How do you convey a message that there is a difference between being compliant and empowering patients to participate in their healthcare? Thank
you, Terry. You're so kind for your words. And that's why we want to drop that word non-compliance and compliant. That tells us nothing. If I say there is a 56-year-old person non-compliant with their medication, that doesn't tell me anything. But if I say to you, there's a 56-year-old person who, when they were taking their medication, got really dizzy and fell and hit their head, and now they're scared to death to take it again, that tells me a story. That tells me a narrative. And you're like, oh my gosh, don't ever take that medication again. I totally understand why you would never want to take that. That tells me a story. You want to encourage your patients to communicate. And you want to encourage that relationship, even when patients do decide they don't want to take it just because they don't want to take it and you believe they should, right? You don't want to ever burn that bridge, right? So they get to choose. And the thing what I tell students, and you don't do it for manipulation either, but you just simply say, I would love for you to think about that. I would love for you to put this in your pocket, take it home, think about it. I do a lot of that with the mammogram. I want people to get mammograms, colonoscopies, get screening for lung cancer. I'm like, I know you don't want to get the mammogram. Please just put the feather in your cap, go home, sleep on it, think about it. You might change your mind in the morning, but I'm not burning that bridge. No way. Nope. Because it's too important that you build that trust and that connection with that person, with your patient. and you respect them. You don't know what has happened. Or if nothing has happened, you're going to respect how they feel.
How do you do that when often the white coat is intimidation for a lot of patients, and they're often afraid to tell you that? How do you bridge that? How do you get over that and help your patient understand that you're really on their team and not just telling them what to do, but helping them live a better life?
That takes time. And I tell them, again, that's something that I say in the beginning, that, you don't know me from anything. And I get it. And, I'm here for you. Call me, my chart me, text me, whatever, I'm really here for you if you have questions. And I take that time, that rapport. I take the time to just get to know them and respect the fact that all relationships take time. Just because I have a white coat on, I don't expect for patients to automatically respect and do as I say. I honestly want to know how they feel, what I'm seeing, how it makes them feel, what they're taking, how it makes them feel. And it's shared decision making. I have a little bit of knowledge in this area, and they have knowledge in many other areas. I'm giving them the knowledge that I have.
Gilbert wants to know, how do you measure a good doctor? Is it based on results or intangibles? And how do they interact with patients, or how they interact with patients?
That is a great question, Gilbert. And I believe that the way you measure a good doctor are both, you can look at things that are tangible, right? So you can look at leadership skills. You can look at characteristics like humility. You can look at service. There are many ways you can look at it. But there are some characteristics that you just can't quantify, right? And I think that some of those things that you can't quantify, but I could tell you what you can do, though. You can definitely measure a bad doctor.
We are just about out of time, Dr. Ilodi. Any final thoughts for our participants?
Well, I just appreciate everyone's just very thoughtful questions. I appreciate the time, Monica, that you have spent doing this Q&A, and thank you, NEOMED.
All right, Dr. Ilodi, thank you so much for a very enlightening discussion. And thanks to all of our participants. Please be sure to join us the first Thursday of next month for another Vitals. Have a great day, everyone.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.